Okay, so hello everyone. Hopefully you all will be fine and you can hear me and my PPT will be visible. If any issue in my voice or you are unable to see the PPT, please let me know and write it in chat box. So before we begin today's session, I would like to sincerely thank everyone who shared such wonderful feedback after our small for gestational age lecture. And I can understand and that teaching of this topic is never easy because it combines fetal growth restriction, Doppler things, and placental insufficiency, surveillance, and time of delivery, complications. So it is one of the most challenging topics in OBS. Trust me. So knowing that many of you can now understand it much better truly makes all the effort worthwhile. So now we will move on to our next very important topic, and this is reduced fetal movement. And students, I always advise that whenever you start reading reduced fetal movements, read together these two other topics as well. And one is obviously reduced fetal movement. Next is small for gestational age. We have just covered it. And third one, this is stillbirth. And why this? Because in real clinical practice and especially in your exam, these topics are closely linked. A fetus with placental insufficiency may first present with reduced fetal movements and later may be diagnosed with growth restriction and may unfortunately it can end into stillbirth as well. So think of them with in a loop, one continuous clinical pathway rather than three separate units or three separate guidelines. So during today's lecture, I will repeatedly connect these topics and explain how these actually guidelines links with each other. So once you understand this relationship, so answering both for your theory and for your OSCE exam will be easy for you, because the management principles really overlap. So by the end of these like all activities, you should have a complete understanding of entire pathway. So let's begin with reduced fetal movements. And again, one of the most important warning sign of fetal compromise and one of the highest yield examination topic in OBS as well. Okay. Okay, so reduced fetal movements is not a diagnosis, okay? It's just a symptom. So, like our job will be to identify whether the symptom represents a healthy fetus or it represents a fetus who is developing placental insufficiency, right? So, like, just start from, basic things, from physiology. What happened? Like movement reflects, we are going to start reduced fetal movement. So what is the physiology of movement? A baby can move if he is having intact fetal brain. Okay, intact fetal brain, intact spinal cord, functioning muscles, adequate oxygenation, sufficient glucose, and healthy placenta. So whenever oxygen delivery falls, the fetus begins conserving energy. Okay, and that's why this is the one of the earliest compensatory mechanism that fetal movements will reduce. So therefore, reduced fetal movements may be the earliest clinical sign of chronic fetal hypoxia. Okay, and there is no mixed number of actually kicks. Don't say like don't tell a woman to count exactly 10 kicks. Instead, teach them every baby has its own normal pattern. A woman knows her baby usual activity better than anyone else. So if she notices movements are fewer than usual or absent, she should seek assessment. Okay, so this is the background. Sorry for taking much time here. And now we are going to start our with our PPTs. Okay. So let's see what's are coming up in these slides. So I already told you patient will come with a symptom, but the symptom is linked with multiple causes. Underlying patient can have placental dysfunction, baby can be malformed, mother can take like if mother is not on a healthy lifestyle or alcoholic or smoker or taking certain drugs, so that they can result into reduced fetal movements as well. Okay, so reduced fetal movement is the presenting symptom for approximately half of our 50% of the IUFTs. So this is very important. We should take it serious. What happen in normal baby or with normal placenta, baby will have adequate oxygenation, will have adequate ATP production, and his muscles will move normally. So in hypoxic response, when there is underlying placental insufficiency, there will be reduced oxygen. And when there is reduced oxygen, so our body blood shunted, the baby body shunted towards the vital organs. We say this is the brain sparing effect. Okay, and brain is vital organ. So baby will go into the energy conservation mode. And because of this, like we will see that mother will come with complaint of reduced fetal movement. Okay, so this is the timeline. Underlying cause can be placental dysfunction, and after this there will be reduced oxygen transfer. And when there is reduced oxygen transfers, then we will first notice the mother will first notice that baby is having reduced movements. And when she will report us, and like when we will evaluate this mother, we will find that her certain investigations are not up to mark, and they can be like abnormal CTG or abnormal Dopplers, and it will result eventually into the stillbirth. Okay, so as I talked about the CTG, every patient we cannot, for every patient complaint who is coming in antenatal OPD with complaint of reduced fetal movements, we cannot offer CTG. CTG we can offer when her gestational age is 26 or more in gestational age time. Okay, so usually mother used to perceive fetal movements between 16-24 weeks anytime. Plateau they achieve at 32 weeks, but it doesn't mean that there will be change in frequency. Frequency will remain the same even before 32 weeks, even after 32 weeks. Okay, frequency does not reduce in third trimester, only the nature of movement change. And one thing is very important, that like baby move more, our mothers perceive more movements in afternoon or evening. Okay, apart from this, baby sleeps as well. So baby sleep cycle lasts like 20 to 40 minutes on average. However, rarely it can exceed up to 90 minutes. Okay, so this is very important before to blame the CTG, because when baby is sleeping, her CTG may look abnormal, like reduced fetal variability or loss of acceleration. So we have to wait for 40 minutes and up to like as maximum as for 90 minutes to label that CTG is really bad. Okay, there are a couple of factors that who can alter the maternal perception of fetal movements, and I will divide them into 3 parts. Okay, so first part is factors that increase the perception of fetal movements, factors that decrease the perception of fetal movements, and factors that have unclear effect. So number 1, factors that increase perception. Okay, so if patient is focused, she will perceive more movements, or maternal with more movements with maternal exercise, with maternal anxiety, or with mealtime. You will see more movements. However, if placenta is anterior, then it means the mother will perceive less movements. It doesn't mean anterior placenta will actually reduce the movements. This is about the perception. Okay, our mother is using some drugs like alcohol, benzodiazepines, methadone. Our baby is having some musculoskeletal or neurological abnormalities. Okay, or you can say mother is simply distracted. So in all these conditions, like mother will perceive reduced fetal movements. Okay, so this is very important to take a standard quality history about all these factors, about factors that increase the perception of fetal movements and decrease the perception of fetal movements. And number third, factors that have an unclear effect. Like there is, this guideline says caffeine, glucose, steroids. Earlier we used to say that steroids are associated with reduced fetal movements, but now this guideline says that it has unclear effect. Okay, our maternal BMI is more. So with maternal BMI, there are more chances of stillbirth. It's not actually directly related with reduced fetal movement. So remember this. Okay. Now, okay. So now this is very important what to do, how to approach in OPD when patient is coming with reduced fetal movement. So first important thing is that like you will greet your patient, you will take brief history about risk factors, who can cause increased perception, reduce perceptions. Okay, and after this, after history, this is number one, you will check the heartbeat. And how will you will check the heartbeat? By handheld Doppler device. Okay, and when on this device fetal heart rate are present, you will check CTG. Just okay, so where we were. Okay, so if fetal heartbeat are present, we will do CTG if her gestational age is 26 or more. And if there is no beat, then what next? So if there is no beat, then you will not jump on CTG. Stay here, okay? And obviously, now this is your responsibility, immediate responsibility to confirm the fetal viability first. And for this, you will go for real-time ultrasound. And here you will see exam question. This is, examiner love this point, that when they give you a buzz that patient is having reduced fetal movements and on auscultation there is no beat, what you will do next, and in choice you will see CTG and scan. So opt scan and real time scan there and then after this event. Okay, this is very important. So if no beat is heard, immediate urgent scan to exclude the fetal death. So if you are able to hear the beat, then what you will do? So there are a lot of recommendations depending on the patient gestational age, and I will discuss one by one every indication. Okay, let me know if you can actually see my PPT. I'm trying. For me, it's visible actually. Okay. Yes. So it depends that what is her gestational age. So stay with me here. Okay. So if patient gestational age is less than 24 weeks, you will check the beat, obviously with handheld Doppler device. And if she says that she never felt any beat and it has been 24 weeks now, Then next is you have to check anomaly scan. And why anomaly scan? To rule out musculoskeletal and neurological abnormalities. Because in these type of anomalies, there is a possibility patient will not feel any movement. Okay, so they will give you exam question. Exactly, patient will be coming before 24 weeks, and she will say she have never heard and perceived any fetal movement. Reduce is something else, and she will say she never felt any movement. So what next? No routine scan, no CTG. You will correlate it with anomaly scan. Okay, very important. Now imagine if patient is coming like during this timeline 24 till 25 plus 6 weeks, what you will do? Obviously history must, and after this you will check the beat. Okay, history and beat, and you will correlate the scenario with beat and history. And again, if no beat, then ultrasound. And if history is significant, you will discuss with your senior, because at this timeline before 26 weeks you can't opt CTG. So you will discuss with your senior and individualize with your senior what to do the next. Now coming towards the most important gestational age, this is 26 weeks. So if your patient is coming at this gestational age, obviously you will take history, you will check the beat, and with this, if beat is positive, you will offer her, if available, computerized CTG. Okay, this is very, very important. And story will not end here. What if she is coming at 28 weeks? So add this an additional thing. If she's coming at 28 weeks or more than 28 weeks, then obviously history, beat, CTG, you will add ultrasound as well. So there are indication of doing ultrasound, So this is the basic ultrasound, and then you will do the targeted ultrasound. And I will discuss in coming up slide about the targeted ultrasound. So there are 3 indications about targeted ultrasound. Okay, so I told you at 28 weeks, everything is same, but you will add ultrasound. Okay, so ultrasound is must. And there are actually targeted ultrasound. Okay, targeted ultrasound. What does it mean by targeted ultrasound? Okay, so apology for this interruption. So where we were at 28 weeks that we will add targeted ultrasound. When we will consider for this additional indication, when patient is having persistent fetal movements despite normal CTG, or patient is having additional risk factors of FGR, our patient says that her no scan done in preceding 2 weeks. So there are 3 indications when you will take action, and this action is ultrasound. And this ultrasound should be targeted. You will actually check abdominal circumference, you will check amniotic fluid volume to rule out placental insufficiency. Obviously, then there will be low 𝗙𝗏𝗄𝗏, and you will check Doppler as well, umbilical artery Doppler, which is the primary surveillance tool in high risk pregnancies, so that you can detect the placental resistance. Okay, so far what we have done, if patient is coming less than 24 weeks, if no movements, she felt never any movement, then an anomaly scan. If just reduced fetal movements, we will check only the beat. And after 24 or before 26, in this timeline, we will take targeted history and we will check the beat. Once 26, we will we will take history, we will check the beat, and here first time we will add CTG. And after 28 or at 28 weeks, we will add ultrasound. Okay, so 4 different gestational age and 4 unique actions. So definitely, if any question will come, it will always come from this as per her risk factors and gestational age. Okay, so do not forget it. Now, okay, when patient is coming with reduced fetal movements, obviously you will take history, you will check her. You will check her beat, you will do her fundal height, check her fundal height if not done already. You will check her blood pressure and urine analysis as well. So this is something new they added in this guideline. Earlier it was not a routine. Okay, and you will also take history in that way so that you can exclude FGR, SGA, placental insufficiency, and congenital anomalies. Okay. Okay, so next slide. Okay, so this is very actually comprehensive algorithm, and if you can understand it well, it's mean you have done 50% of this important guideline. Okay, so see, when patient is coming with reduced fetal movements, this is the care pathway. Attend with presentation of reduced fetal movements after 28 weeks. Okay, we already know what to do before 24, 24 till 26, and after 26. And particularly, we are standing here now after 26 at 28 weeks. So we will take history, number 1, and history should be targeted so that we can rule out stillbirth and FGR risk factors. Okay, so if history confirmed that patient is having reduced fetal movements, so after history, first thing is beat, Doppler, hand Doppler device, or you can use stethoscope as well if not available, so that we can comment on viability. And if fetal heartbeat not present on auscultation, then immediate ultrasound so that we can exclude the IUFD. And so what you will do if there is IUFD, then here you will follow the Green-top guideline of stillbirth or IUFD. Okay? Okay, so now focus here. Patient coming up, she is 28 weeks and beyond. You have taken history. History confirms she is having reduced fetal movements. You have auscultated her and you found the beat. But what you will do next? You will add CTG here. And if CTG is normal heartbeat, our 4 parameters of CTG. One is baseline, second is acceleration, third is variability, fourth is deceleration, you will comment. So on these 4 parameters, and obviously with risk factors and contractions, maybe she can have labor, preterm labor or term labor. So you will assess the CTG, and all these parameters are normal. And CTG, what CTG can tell us? CTG can tell us only the acute event. It cannot exclude the chronic events or chronic hypoxia. So if there is any concerns, what you will do to rule out the chronic hypoxia, whether CTG is normal even, but in risk factors, you will opt or advise targeted ultrasound here. And here on this ultrasound, you will check particularly abdominal circumference, estimated fetal weight, Likert, and Doppler. Okay, this is most important. However, perception of fetal movements resolved and no risk factor of stillbirth. So what you will do, you will reassure her, give advice regarding further episodes of reduced fetal movements. That's it. Okay. Now look at here. If patient is coming after 28 weeks, right? And you have taken history confirmed rotated fetal movements, you have checked the beat is there, you have done the CTG, but CTG is suspicious or pathological. So what you will do? You will manage as per unit protocol. So if it is only suspicious, like reduced variability, and for in reduced fetal movements, CTG trace time is 20 minutes. So probably in this time, if you see reduced variability, baby can sleep as well. In sleep cycle, there will be reduced variability and no acceleration. So you have to wait for up to 40 minutes and as long as 90 minutes to comment that CTG is really pathological. Okay. Do not take any aggressive decision here, particularly like patient is at 29 weeks, reduced fetal movements, and CTG is showing reduced variability only and no acceleration, and 20 minutes has been passed. So what you will do? Cesarean section? No. Repeat CTG. Okay. So baby will be only, normal baby will be having in this sleep cycle. He will react after 40 minutes and CTG will be okay then. And you can, plan to keep her conservative. And if up to 40 minutes and rarely up to 90 minutes, if there is no improvement in variability and no, you can't appreciate acceleration, then this is, alarming CTG. And here you will involve your consultant, will discuss the situation with patient, will think about discussion of steroids and early delivery, max sulfate, so many things you will, plan here. Okay. So now I'm hopeful you will have better picture in your mind. So again, very basic things about CTG. One thing is more. This guideline also address multiple pregnancies as well. This says that investigate both babies with CTG where appropriate, fetal growth, and investigate both babies and check Likert and Likert Doppler of each baby. Okay, so this is new in this guideline. Earlier, in previous guideline, they have excluded how to address multiple pregnancies. Okay, so this guideline address single and multiple both pregnancies, and everyone knows that when baby is sleeping, so and patient is coming with reduced fetal movements, and during 20-minute trace there is no variability, we should continue to actually do the CTG till maximum 90 minutes. So between this timeline, if still if baby will be really hypoxic, he will not improve after this. Okay, after 90 minutes maximum, if baby is really hypoxic, will he improve? No, the CTG will remain bad, reduced variability, late deceleration can develop. So this is, acute compromise condition. But if baby is well, sleeping, just sleeping, and mother become concerned that there is no movement and you have done CTG and between 20 minutes CTG, no variability, you can continue the CTG till 90 minutes. And if baby is, well, in after this, the fetus will wake up. Maximum rarely baby can sleep up to 90 minutes. So movements will resume after 90 minutes. Acceleration will appear. That's it. This is a reactive healthy baby trace. But this is only looking at, real-time fetal distress. Still with this normal CTG, if still baby can have placental insufficiency. So any risk factors, do not forget to add ultrasound to check Likert and, MRCPI. Okay. Now, so what is SGA? SGA means healthy placenta, normal Doppler outcome, naturally small but healthy. Okay, we say this is a constitutionally small baby. And what is fetal growth restriction? Failing placenta, abnormal Doppler, abnormal Likert, and outcome will be hypoxic environment requiring managing as per our with the guideline which we have discussed about SGA. Okay. High risk presentations, if patient is coming with, recurrent reduced fetal movements. So what we will do, we will discuss with our senior, must review to exclude predisposing causes, and always include ultrasound, targeted ultrasound. And if patient is having multiple pregnancies, then again we will check each baby for each baby for Doppler. Okay. However, our action plan may vary depending on the chorionicity and multiple pregnancies, own complications like TTS, and if anything is positive or abnormal here, then we will manage this situation as per multiple pregnancies guideline. Okay, there are two guidelines, one NICE and one GTG, which will cover it. Okay, so I will discuss before 39 and after 39 situations in a while. Okay, so just focus here that as I earlier told you that now they have removed count to 10 kick charts, because now they said individually discuss with each woman about her own fetal behavior. It can vary. Okay, and normal strategy does not entirely exclude growth restriction. If there is any indication to do Doppler and check growth velocity. And like if patient is having sudden or fast or acute reduced fetal movements, so it doesn't mean that it will be due to the anterior placenta with established risk factors. So always take it serious. Okay. Now I will read some theory things, but you can understand now better if because of this background information. So remember, take reduced fetal movements very serious, because it is associated with 29% SGA, 5% severe FGR, and up to 50% cases who diagnosed as IUFD, their first presentation usually would have been reduced fetal movements. Okay, and if what is the definition of absent fetal movements? If it has been 24 hours and patient has not perceived any movement, we say this is absent fetal movement, and usually it ends in the diagnosis of IUFD. Okay. However, generally, if patient is having normal movements, then risk is very low. So always educate patient at booking about the movements, and she will start perceiving movements between 16 and 24 weeks, and discuss about the circadian pattern. She will have peak time of movements in evening and after meals, and usually multi-perceive earlier than primary, increase frequency till 34, then plateau, and then it will stays normal. It does not reduce the quality, just change. And it's not true that I told you that like quality will change, not the frequency. However, repeated episodes make outcome poor. Obesity will not affect perception, but it has higher stillbirth risk. There is no set of number. Normal movements in every pregnancy, it is different. Usually, baby will have their own pattern of movements that patient should get to know. So, importance to report any change as soon as possible. Okay. In during antenatal visits, every time talk about the fetal movements. Whenever she perceive any change, she should come as soon as possible. Okay. Mother should continue to feel her baby move right up to time she goes into the labor. Even you must not wait until the next day to seek advice if you are worried about baby's movements. Means a patient having reduced movements today, so she should not wait for tomorrow. She should come as soon as possible. And every patient should have been given patient leaflet information before 24 weeks, what to do if she ever feel reduced fetal movements. Okay. So I have compiled many sources to complete this topic, and I have added PIL, patient leaflet information as well, so that you can understand your 𝗏𝗏𝗃𝗃 task as well. I'm not teaching this lecture for 𝗏𝗏𝗃𝗃 purpose, but if I am adding your like 𝗏𝗏𝗃𝗃 scenarios, then you can better understand it even for theory purpose. Okay, because clinical examples make your understanding better. So remember, whenever patient comes with single episode, take it serious, educate her about, and take history about like this is first movement, second movement, any history of drug intake, because there are certain drugs which are associated with this, and then examine her, check her blood pressure, check her Proteins in urine, very important. They first time added in this guideline. Then palpate her abdomen and measure her fundal height. And if she says any PV leaking or bleeding, then examine that to assess fetal well-being. Do CTG if her gestational age is 26 or beyond. Ultrasound if indicated. Okay, and these are the overall indications which I compiled from stillbirth and SGA guideline as well. When patient is having reduced spindle height, not done since 3 weeks, okay, and her CTG is not good, or it is her recurrent episode, or she's having other multiple risk factors which are high risk factors like diabetes, hypertension. And regarding biophysical profile, the first time in this guideline updated this, that biophysical profile has no role in actually reduced fetal movements. It's not helpful in improving the outcome, but sometimes it can be just reassuring. Okay. However, if any abnormality anywhere in history, in examination, in BP, in urine, on examination, manage it. However, if like CTG is normal and on history examination patient is low risk and gestational age is less than 39, you can discharge her, but keep her on follow-up advice. Like if she ever perceived reduced fetal movements, she should contact us. Okay. And if her gestational age is 39, or she's having, even if she's low risk, but if she felt reduced fetal movements at or after 39 weeks, then better to discuss with your consultant and discuss about about delivery. At this timeline, at 39 weeks, even patient if it is low risk even, it's better to deliver. They said delivery at this time is not associated with neonatal mortality or morbidity. Okay, so probably I guess one question is coming up from this: what you will do before 39 weeks and what you will do after 39 weeks. Okay. Total overall rule is that if like patient is normal but high risk, then correlate with gestational age, correlate with patient concerns, make her individualized plan, but do not intervene unnecessarily. So, and your aim should be avoid the preterm delivery. Okay. So if indication, then go for delivery. Otherwise, do not actually over-investigate her. Like here they said individualized plan. Like if patient is having reduced fetal movements and it's twin pregnancy and one baby is having like a more and one less. So this is TTS. So here you will individualize. You will individualize as per TTS, what to do before 26, after 26. And like if reduced fetal movements with abruption, then different management, reduced fetal movements with preeclampsia, different managements, reduced fetal movements with reduced Doppler, then different management, or absent Doppler, different management. Okay. So you will individualize in this situation as per the provided condition. Now, you have taken the targeted history, you have asked about the onset, duration, number of episodes, and like you have checked its relation to being focused or busy, things she tried to improve, like if she has not taken meal or something like that, or if she has used any drug, or you have checked her CTG more than 90 minutes and still abnormal, and you will correlate with these all situations, and then you will make a comprehensive plan what to do, how to do, and in what way you should intervene. Okay, like if baby is having anomalies and they are lethal anomalies, maybe you will be discussing and referring in MDD with termination, so many things. Okay. Yes, smoking is associated with reduced fetal movements. Okay. Okay. If a baby is compromised, what will happen? You will see abnormal Dopplers. Okay. And like if patient having low PAPA in first trimester, then it is also associated with SGAs and so many. Actually, if a patient coming with pain leaking, then it can be due to the anemia, hemorrhage as well. So remember, reduced fetal movements may be the presenting symptom for IUFD, for FGR, for malformation, for placental insufficiency, for fetal-maternal hemorrhage, and in multiple pregnancies, even with TTS. So history is important, examination is important. And after history and examination, you will individualize the whole scenario. You will categorize your patient in which category she falls. This is that much important. History and examination. It will change your management line. A patient is high risk. So what type of risk is this? What type of this? TTS? Like chronic hypertension, complicated pregnancies, cardiac patient. This is very important. And if anything, a patient is coming with established chronic disorder, then manage the situation as per that disorder, as per CTG, as per gestational age, viability and no viability, as per your capacity to entertain, like deliver this patient in your setup. Okay. So yes, few theory things again. You will check your patient if her gestational age is 26 or more by CTG, ultrasound, if any risk factors. I told you 3 risk factors, and if anyone, like if healthcare professional think so, on additional risk factors, he can additional plan ultrasound as well. And how you will define recurrent movements. Recurrent reducible movements definition I have not taken from this guideline, neither they have provided. Okay, so this is this is just a consensus. 2 or more episodes of reducible movements occurring within 21 or 3 weeks period after 26 weeks. We say this is reduced fetal movements. If a woman reports reduced or absent movement, she should not be told to wait for 2 hours even. Okay, and monitoring should you start within 2 hours. Women reporting to no movement should be seen as soon as possible. And you should discuss steroids as well if you are considering perpetuum delivery with because of normal trace. Okay. Next. So this is summary. A patient is coming before 24 weeks. You will check the beat. Okay. And if she says she never felt any movement, you will add an anomaly scan. Between this timeline, you will check the beat. Obviously, history examination is first in every situation. Here, 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 here. After this, you will check first beat and correlate it. And after 26, you will add CTG. And after 28 weeks, you will consider ultrasound, targeted ultrasound. Okay. So before 39 weeks, you will intervene, like induction or operative delivery is associated with small increase in fetal morbidity. Thus, decision of delivery needs to be based upon evidence of fetal compromise, like if abnormal CTG or FGR or oligo or abnormal Doppler or other outcome. Or like mother is having diabetes, hypertension, in addition to the reduced fetal movements. So basically, if gestational age is less than 39 weeks and patient is low risk, so better not to deliver. However, if high risk, less than 39 weeks, so what is the risk? Diabetes, hypertension, diabetes, whatever, cardiac. So manage on according to that guideline. Okay. Number 2, if patient is coming after 39 weeks, they said at 39 weeks, induction is not associated with increased section, operative delivery, fetal morbidity, or admission in NICU. Therefore, if recurrent reduced fetal movements at 39, specifically recurrent, even at single as well, after 39, you can discuss induction. You will check, and for induction, you will do her PV and you will check her Bishop score, and will decide the mode of induction, whether you should induce by ARM or by prostaglandins. Okay. So after 39 weeks, a single episode, you can discuss induction. And after 39 weeks, if recurrent reduced fetal movements, you can discuss induction, even with a normal test, because 39 has been passed. Before 39, you should stay here. You should discuss whether low risk or high risk. Low risk, do not go for induction. High risk, then decide as per the risk. And between this timeline, 28 and 39, low risk, single episode, CTG is enough. That's it. Okay. And on, like, if high risk, then you will add ultrasound as well, or specifically with not done within 2 weeks. Okay. Okay. Now, what is the, I was just out of curiosity, I have searched exaggerated fetal movements. This guideline does not entertain exaggerated movements, but the women used to describe this exaggerated women are crazy, are like a seer suggested. Perception of a single presentation of exaggerated fetal movement is more frequent in women who have a stillbirth, especially if followed by the reduced fetal movements. Like if patient is having risk factors, first she says she perceived reduced fetal movements, and then she said that she's having exaggerated movements. So this is important. Take it serious. Okay. Now about the CTG, and they said type of fetal heart rate monitoring. We can do intermittent auscultation using handheld Doppler and Pinot. Antenatal CTG done before labor, for example, in reduced fetal movements, fetal growth restriction, hypertension, diabetes. Then we have computerized CTG, which we analyzed by Davis-Redman criteria. This is important. What is Davis-Redman criteria? We have discussed this in our previous SG lecture as well. And then intrapartum CTG, and then actually CTG, which work like ECGs and, check ST analysis. So there are a lot of tools which are used for fetal heart rate monitoring. Okay. So in CTG lecture, we will discuss everyone. This guideline does not add details. And this is very important. Normal antenatal CTG parameters. Heart rate should be between 110, 160, variability 525 beats per minute, accelerations, reassurance. It means intact autonomic nervous system. This is a very good indicator, specifically in the background of reduced fetal movements. Deceleration should be absent. Overall, there should be, no evidence of acute fetal compromise. Obviously, we will add contractions and determine the risk as well. Okay, CTG alone we cannot interpret. With clinical background, we have to interpret it, this CTG. So suspicious CTG, one non-reassuring feature, but no clear pathological feature. Like only one feature is only variability is reduced. That's it. Rest all three parameters are okay. Okay, and pathological CTG means one red feature or several other concerning features. We will discuss this in CTG lecture. What is red CTG? What is white CTG? What is amber CTG? So what is Davis-Redman criteria? We have already discussed in SGA. You can read it now. It is used for from 26 onward weeks in patients who comes with reduced fetal movement. And this computerized CTG, which we analyze on this criteria, its role is to provide the objective assessment of the fetal heart rate pattern. It helps to assess the fetal well-being and short-term variation. Okay, and it reduces the inter-observer variation, means staff nurses saying something else, R1 saying something else, ST5 saying something else. So computerized CTG remove the subjective or inter-observer variation, and this is more sensitive. So what does Davis-Redman criteria means? Davis-Redman criteria are the computer checklist for antenatal CTG. The computer check whether the trace has enough reassuring features for the gestation. The report prints either criteria met or criteria not met. If the criteria are not met, the machine usually gives a reason as well. We have discussed this in previous lecture. Now this is just a screenshot about time of CTG. In reduced fetal movements, CTG trace time is 20 minutes, and it can be as high as, up to 90 minutes, because sometime rarely healthy baby can sleep till 90 minutes. And during this time, CTG will show reduced variability and no acceleration. So, for example, remember, suspicious CTG only reduce variability, no deceleration, everything rest is normal. You can continue CTG till 40-90 minutes, and you will check maternal observations as well. You will say her to stay in non-spine position, hydration if needed, review medications, and assess risk factors and involve senior. Okay, however, after doing all these things, if there is a persistent reduced variability or worsening CTG even, then immediately involve senior DCN, consider ultrasound if indicated, and consider delivery depending on gestation and whole clinical picture. And pathological CTG means, red features and, decelerations, bradycardia, acute fetal compromise, sinusoidal CTGs, they need expedited. So this is just the comparison of previous guideline. You can skip it. And on the repetition of our previous detail, no role of biophysical profile, and stay here. This is very important. See, you know what is CPR? Cerebral placental ratio. Cerebral placental ratio means we divide middle cerebral artery Doppler with umbilical artery Doppler, and we see the ratio. It is 1.1 or more. Okay, this is CPR. First time in this guideline, they have added this, that they have conducted a very good trial, and on this trial they divided the patient in two groups, in group 1 and in group 2. In one group they take decision on base of CPR, and in group 2 they have taken the decision on only clinical things, and they found that group 1 performed well where they have taken the decision on CPR. Okay, where they have checked that CPR was less than 1.5, and they took it serious after 37 weeks, and they planned the delivery or expedited the delivery. These babies perform well. These babies perform well. So CPR has importance. If patient is having reduced fetal movements at 37 weeks, if you are adding CPR, you can plan induction if her CPR is less than 1.1. Okay, this is very important. Now, this is just repetition. They have decided, this is a very good trial, group 1 and group 2, and they found that the group in which CPR was used to guide the management had 24% lower risk of adverse neonatal outcome. And most of the benefit came from a reduction in the neonatal morbidity. So this tool is very important and can be utilized in clinical setting if available. A 38 weeks pregnant patient, CTG is okay, but movements are not okay, and estimated fetal weight is okay because 45th percentile, it's okay if estimated fetal weight is between 10th and 90th percentile, and CPR ratio is less. So this is not okay. See, her age, she is at 38 weeks. So even if she is low risk, even her CTG is okay, even the baby growing well, but CPR if we are adding, and if it is less than 1.1, which is 1.9 here, so here we can discuss induction. After 37 weeks, CPR can guide us for induction, and this baby may benefit from this. They will have less neonatal sequelae. So I will guess one question is coming up from here as well. And this is just a repeat slide. Yes. And just a repeat slide. And we have already done this algorithm. And we have done this as well, but to do it before 28, after 28. Okay. See. Revise this. Before 24, Doppler heartbeat. That's it. Can add anomaly scan if needed. 24, 26, Doppler heartbeat and risk factor. Okay. 26, 28, Doppler heartbeat, CTG. After 28 weeks, selective ultrasound, targeted ultrasound, you can say. Okay. Okay, and what is the role of ultrasound assessment for fetal biometry like volume and molecular Doppler? Evidence quality 2+, ultrasound scan assessment should be undertaken as a part of the preliminary investigation of a woman presenting with reduced fetal movements after 24 weeks of gestation if the perception of reduced fetal movements persist despite a normal CTG, if there are any additional risk factors for FGR or stillbirth, and if an ultrasound has not been performed in the last 2 weeks. Okay, like if patient is coming at 28 week and at 27 weeks her scan has been done due to any reason and it was okay, so no need to repeat ultrasound. But if no ultrasound has been done in last 2 weeks, then if reduced fetal movements at or after 28 weeks, then you have to do her selective ultrasound. Okay, this is one indication. However, there are 3 indications we have already discussed. One question can come from here. So again, we have covered this, and this is summary only. Fetal kick count chart is no longer recommended. First fetal movements may be perceived from 16-24 weeks. Regular fetal movements pattern is established by 28 weeks. Under 24, confirm fetal heartbeat. And after 39, birth can be considered through shared decision making if patient is coming with reduced fetal movements or with recurrent reduced fetal movements or with risk factors. So here is a movie for you, and if you have time, this is only 6-minute long CTG movie, and it will make your life easy. Okay, stay with me.
Warning signs we have for impending fetal demise.
Okay. Okay. Now it will be audible.
Imagine a patient presents at 38 weeks gestation. Her vital signs are stable, but she tells you, "My baby hasn't moved as much today." You are now faced with a clinical paradox. The symptom, reduced fetal movement, is entirely subjective, varying wildly from patient to patient. Yet it is one of the most reliable warning signs we have for impending fetal demise. In the UK, over 1/3 of unexplained term stillbirths are directly tied to placental dysfunction. When a mother reports decreased movement, that single data point branches into 2 distinct realities: a healthy delivery or hidden placental failure and stillbirth. Mastering the clinical pathway for this presentation is how you prevent an otherwise unexpected tragedy on the maternity ward. We approach this by dissecting the 2026 RCOG Green-top Guideline No. 57. This document provides the evidence-based framework for evaluating these patients. Today, we will trace the exact pathophysiology of placental failure to explain why traditional methods, like having patients count their baby's kicks, fail to protect them. The modern clinical algorithm operates on a three-tiered logic of exclusion. We exclude a lack of viability, we exclude acute autonomic compromise, and finally, we exclude a lack of chronic placental reserve. Your clinical success relies on taking a mother's subjective awareness and running it through this rigorous sequence of objective diagnostic exclusions. Let's start by dismantling a pervasive myth. You will often hear that fetal movements naturally decrease in the third trimester because the baby simply runs out of space. This is anatomically false. As the fetus matures, the character of movement changes. Kicks are replaced by rolling and stretching, but the frequency and strength do not drop. Reduced fetal movement is an active, energy-conserving neurological adaptation to a hypoxic environment. When the placenta fails, it delivers less oxygen. The fetus prioritizes its most vital organ, rerouting available oxygen to the brain, a mechanism known as brain sparing. As peripheral oxygen drops, the fetus stops moving limbs to conserve energy. Because of this direct physiological link, you cannot attribute a sudden reduction in movement to a high maternal body mass index or an anterior placenta. Dismissing reduced movement as a mechanical issue masks the earliest neurological proxy for placental failure. For decades, the standard response was to give the mother a chart and tell her to count to 10. Extensive clinical trials by Grant and Sostad demonstrate formal kick-counting charts fail to reduce perinatal mortality. Applying rigid numeric thresholds to vast populations causes a sharp increase in false alarms, leading to unnecessary inductions in healthy pregnancies. Conversely, an arbitrary limit, like 10 movements in 2 hours, fails to capture a gradual decline in a compromised fetus, whose unique normal baseline might have been 30 movements. The updated RCOG standard removes these arbitrary numbers. The focus is entirely on the mother's subjective awareness of her own baby's individual baseline pattern. Shifting away from kick charts acknowledges that rigid data thresholds are ineffective against a highly individualized physiological decline. When a patient presents with reduced movement, the immediate first step is to auscultate the fetal heart to confirm viability. Once viability is established in a pregnancy of 26 weeks or greater, the primary tool for acute assessment is the computerized cardiotocography, or CCTG. We use the CTG for a specific physiological objective, testing the integrity and reactivity of the fetal autonomic nervous system. This is a major diagnostic challenge. You must differentiate between a healthy fetus and a normal sleep cycle, and a fetus experiencing pathological autonomic depression. On the left, a sleeping fetus. On the right, a hypoxic fetus. Initially, both traces show identical reduced baseline variability, but normal sleep cycles last 20 to 40 minutes. Continuing the trace on the left, the baby wakes up, variability returns, and accelerations appear. Fetal sleep rarely exceeds 90 minutes. If we watch the hypoxic fetus on the right, the lack of accelerations persists, and we eventually see the onset of late decelerations. This is why the guidelines require an initial minimum of 20 minutes, but acknowledge that you may need up to 90 minutes to confidently clear a sleep cycle. Acute assessment requires extended monitoring, specifically because acute hypoxia and physiological sleep share the exact same initial autonomic presentation. A reactive CTG confirms acute autonomic health in that specific moment. It does not evaluate chronic placental capacity. We escalate to further investigation if there is persistent maternal concern despite a normal CTG, or if the patient has baseline risk factors for stillbirth. These risk factors include known growth restriction, hypertension, extremes of maternal age, or significant past obstetric history. When those triggers are met, we move to ultrasound, looking at 3 specific targets: fetal biometry, liquor volume, and the umbilical artery Doppler. We check biometry and liquor volume because a small for gestational age fetus and 𝗚𝗏𝗲𝗏𝗏 represent long-term adaptive failures of the placenta. We check the umbilical artery Doppler because abnormal waveforms directly indicate rising vascular resistance in the placental bed. Escalating to ultrasound completes the clinical picture. It proves whether the placenta can sustain the fetus long-term, moving beyond the immediate snapshot provided by the CTG. Let's review the complete algorithm from subjective presentation to objective diagnosis. The patient reports reduced fetal movement. 𝗚𝗂𝗶𝗱𝗃𝗏 you perform a computerized CTG to confirm acute autonomic function, and you use ultrasound to verify chronic placental function. This brings us to the final clinical decision. Do we expedite birth? If all objective evidence returns normal, meaning a reactive CTG, normal growth, fluid, and normal Dopplers, you can reassure the patient. There is no indication to induce labor. However, if the patient returns with recurrent episodes of reduced movement and she is past 39 weeks gestation, the criteria for considering early delivery are met. At this gestational age, expediting birth for recurrent reduced movements does not carry an increased risk of adverse outcomes for the mother or the baby. Treating a mother's subjective report of reduced movement as the earliest neurological proxy for placental failure allows clinicians to preempt stillbirth through a calculated, evidence-based exclusion of risk.
Okay, so let's solve now few questions, and after this, you will be master in reduced fetal movements. So look at here. A 30-year-old patient, primary gravida, at 31 weeks, asked whether she should use Cardiff count to 10. Can we use? Because now it's not recommended. So what you will say? No need of this, because every pregnancy is different. Every, fetal movement is different. So advise awareness of her own usual movement pattern and report any reduction at the same day or as soon as possible. Okay. Now this 𝗙𝗟𝗃𝗏, 17 weeks anxious, and because she has not yet clearly felt fetal movements, she has an anterior placenta scan. She asked about whether this is abnormal. So what is the most appropriate response? So fetal movements may be first perceived between 16 and 24 weeks. Okay, so we will say this, she can wait till 24 weeks, and at this timeline, if she is not going to perceive, then we will check her anomaly scan, correlate with her anomaly scan. So next patient is at 23 weeks and she has not felt. So we will add here anomaly scan. Confirm fetal heartbeat. What? Okay. No, this is not primary issue. She has not felt fetal movements today only. Earlier it was normal. So we will just check the beat. That's it. Okay. And the last question is that patient is at 25 weeks with reduced fetal movements and beat is there. She is high risk. She is having chronic hypertension. So what is the most appropriate next step? We will take history and assess for risk factors for stillbirth or early FGR. And obviously, as per her chronic hypertension, we will approach her. Okay. So this is about today's class. If you have any query, let me know and practice more questions.